afternoon, everyone. Thank you so much for joining me today for Continuum of Care, looking at care options as we age. My name is Lauren. I am the Educational Services Manager here at Alzheimer's Orange County, and I will be the presenter for today. At any time, if you have any questions, or you can either put it in the chat box, you can come off mute and ask your question directly. We have a lot of information to go over today. So this webinar or this presentation will be recorded, and I will also be sending out the slides afterwards. So again, any questions, please feel free to ask. I would like to thank Anaheim Public Library and specifically Lucky for sponsoring and co-hosting these events. It creates this opportunity for us to present education to the community. Our goals for today are to understand the stages and options within the continuum of care. We want to learn the pros and cons of in-home, out-of-home, and end-of-life care, explore real-life consequences of poor planning, and identify tools and strategies to prepare for care needs. I want to briefly talk about Medicare versus Medi-Cal. Sometimes they're often used interchangeably, or people aren't sure which one they have, but they are two very different types of insurance. Medicare is age-based. It's for those that are 65 years and older. However, if you have a severe disability, you may qualify for Medicare earlier in your life, but more or less it's specifically for those that are 65 and older. And then there's Medi-Cal, which is income-based. You have to be of lower income to qualify for Medi-Cal. There is no age requirement, but there is a limitation on assets. Medi-Cal is California's version of Medicaid. And when I talk about who pays for what today, I'm talking about Medicare and Medi-Cal as it stands right now. I know that there will ultimately be some changes in the coming years of what Medi-Cal will and won't cover, and same with Medicare. So as I talk about that today, just know that I'm talking about what Medicare and Medi-Cal cover as it stands today. And then a little bit more on Medicare. Medicare consists of 4 parts. There's Medicare Part A that covers hospital stays. There's Medicare Part B that is more direct medical coverage, such as your doctor's office or home health. There is Part C, which is the Medicare Advantage plan. So when you elect for someone to manage your Medicare benefits, that's covered under Part C. And then there is Part D, which is your prescription coverage. So those 4 parts make up Medicare. Again, it's a lot, it's confusing, but so if you have questions, please feel free to ask. What is the continuum of care? Why are we here today and talking about this? Continuum of care consists of at-home care. It consists of assisted living, memory, rehabilitation, there's skilled nursing. It varies depending on how much care that we need. Sometimes we can live at home independently. We need more acute care. We'll go to a hospital or a skilled nursing. Sometimes we only need moderate care and we'll end up in maybe an assisted living or a memory care. These are not just you go to an assisted living and that's where you live and pass away. This transitions over time. You may be at home, you go to hospital, skilled nursing, you go back home. Maybe you go from home to skilled nursing to assisted living. Maybe you move into assisted living and then you move back home. So it's always, there's ebb and flow with the continuum of care. And I have a couple scenarios that I want to go through with you, and they seem very dramatic. And maybe not something that you're very familiar with, or you're like, oh, it would never get that bad for my loved one, myself. I have been in this industry for almost 20 years. I have seen it all. I have had these conversations time and time again, specifically when I was in skilled nursing services and I was overseeing the social workers, and families would come in and I'd say, okay, what's mom's discharge plan? And they wouldn't have one. Oh, we'll get there. We'll get there. We'll figure it out. And by the time we were ready for discharge, they didn't have any idea. They didn't know where mom was going to go. They didn't know who was going to care for her. They didn't know what was available or who was going to pay for it, despite trying to have that conversation the entire time. So it's really important as we talk about this today. Maybe you're not there yet, maybe your loved one's not there yet, but to have an idea of what is it that I want? What's available to me? What can I afford? Are there specific companies? Just really knowing what's going to be out there for you. So this story is Mrs. Green. She falls at home and is hospitalized. Mrs. Green has no power of attorney, no family nearby, and no in-home support set up. So she's discharged from the hospital to a skilled nursing, but while she's there, she refuses care, and she also has no plan in place for returning home. Eventually, her Medicare days run out, and her family has to scramble and pay out of pocket for care cost. So the key message in this is that without planning, crises force quick, costly, and stressful decisions. Next is Mr. Rodriguez, who has been hospitalized for pneumonia and goes to a skilled nursing facility for rehab. Mr. Rodriguez lives alone, cannot manage stairs, and has limited income. He has no plan in place for assisted living and no family available to support him. Eventually, his Medicare days run out. He has nowhere safe to discharge, and so he must become a long-term Medi-Cal resident in the skilled nursing facility. And the takeaway from this is that without discharge planning and care arrangements, people can end up in institutional care that they didn't want. And lastly, we have Mr. and Mrs. Johnson, who are both in their 80s and live at home. Mrs. Johnson has mid-stage dementia and mobility issues. Mr. Johnson is her sole caregiver. He refuses in-home care or assisted living, insisting it's his job and he does not want strangers in the house. Over time, caregiving becomes overwhelming. He forgets to give her medications, she falls multiple times, and he stops attending to his own health. This results in Mrs. Johnson being hospitalized 3 times in 2 months for UTIs and dehydrations, and Mr. Johnson experienced a minor stroke due to stress. Eventually, social workers have to intervene. And the key message in this is that refusing help doesn't protect your loved one. It can lead to preventable hospitalization, caregiver burnout, and crisis-driven decisions. So planning is an act of love. Okay, let's get into it. So first is in-home care options. And as we talk about this, think of staying at home, is it realistic? And factors that we always want to consider are physical and cognitive abilities, home safety, and support systems that are in place. There are several types of in-home care. And when I say in-home care, I mean that care you can receive wherever you call your home. So if you're living in an apartment, if you have, a house, or you living in assisted living already, these you can still receive while living in your home. There are companion care and personal care aides. There is home health, and then there is palliative care and hospice. And we will go through each one of these. Companion and personal care is non-medical care. You are hiring an individual to come into your house and assist you with whatever it may be. It can be companion care because you need to leave for the day and have someone sit with your loved one for a couple hours, or maybe someone's coming in to do activities of daily living, such as meal preparation, helping with dressing or grooming. Maybe they're just ensuring you took your medications in the morning. Maybe you just need someone to go with your loved one to a doctor's appointment and provide that extra support, or they take you to the grocery store. It can be for whatever you decide that you need help with. And it can be for however many hours you need. So it can be 4 hours a day, twice a week. It can be once a week on a specific event. It can be continuous 24/7 care. It is determined specifically by the individual of what type of care that they need. And where do you find an in-home caregiver? You can reach out to in-home care agencies. So these are companies that are licensed and insured, and they provide caregivers. Or you can go for a private caregiver. And this may be a family friend. This may be someone you've met off the internet. This can be someone telling you, oh, I used this person several years ago and I really liked them. In-home care agencies will typically be more expensive than hiring someone directly, but you get the benefit of having someone who's insured. Their staff is going to be well trained, If someone calls out sick, you'll have coverage right away. If you don't particularly like the person that's caring for your loved one or for yourself, you can always call and request someone different. So there is more flexibility. But again, it's going to be a little bit more expensive, and we'll talk about costs in the next slide. Versus a private caregiver, that's going to be specifically between the two individuals of what that cost is going to be. So there is flexibility in the cost. But again, if they call out sick, who is your backup coverage? If you hire them and you don't like them, what's your plan? So it can be, and they're not typically not insured. So if anything happens, there is something called in-home supportive services, or IHSS. This is through Medi-Cal. So again, for low income, you could either say, I want my family member to be my IHSS caregiver, or IHSS can supply one for you. It's very limited hours, but Medi-Cal does cover the cost. And then there are VA benefits. So if you're a veteran, you may qualify for the Homemaker program, and there are companies that are contracted with the VA and can supply that. Now, to look at the cost of caregivers, again, in-home is going to be about 25 to 40, closer to 40, depending on location. Um, Usually, if you go more hours in a day, it'll be a little less overall. So let's say you want someone for 4 hours a day, that'll be maybe $30 an hour. But if you have somebody for 24 hours a day, maybe it'll be about $28 an hour. So usually the more time you have somebody in one day, it'll be a little bit cheaper. Again, the private caregiver is going to be based off of what the two of you decide and establish. And then for long-term care insurance, if you have that in place, they may offer reimbursement. Medi-Cal, again, only covers in-home supportive services. Medicare and Medi-Cal do not cover any form of in-home care. And again, IHSS is going to be about 283 hours a month. That's max. And that's not a lot of hours for someone who needs a lot of care. So again, with in-home care, you're looking at spending that out-of-pocket cash cost. Now, on the other hand, we have home health. And a lot of times I found people get in-home care and home health. They think they're the same thing, or they're not quite sure what home health does. And so, for instance, when I would be talking to someone who's discharging from skilled nursing, and I'd say, okay, who's going to take care of you and help you around their home? They're like, oh, I have home health set up. I'll be fine. Now, home health is skilled medical and supportive specialized care services in your home in the form of a nurse coming to your home, physical therapy, and occupational therapy. And these are going to be for a very short period of time. The goal is to help you recover from an illness or to regain your independence. They can provide wound care, IV therapy, or they can monitor an illness. So, for instance, someone going home who may have a wound, may have a feeding tube, they may require extra care, but are no longer appropriate for a hospital or skilled nursing. So a nurse will come out, however often is determined from the care plan, 2 times a week, 3 times a week, maybe for about 20, 30 minutes at a time to provide that specific care, and then they leave. Same with physical therapy and occupational therapy. It's a very short visit for a very specific goal, and then they leave. Versus an in-home care provider who is there to provide and assist with any of the activities of daily living that you need. Again, home health is going to be very short term. You'll need a doctor's order, and it's to help you recuperate. So to look at these side by side, home health is considered a skilled nursing service, while in-home caregiver is non-medical care. Home health will provide professional medical assistance. In-home caregiving provides support and companionship. Again, home health is physical therapy, occupational therapy, wound management, speech therapy, IV medications. In-home caregiving is strictly companionship, assistance with dressing, grooming, meal preparation, and other activities of daily living. Home health you can only get with a prescription from a doctor, and in-home caregivers you can get whenever you need. Home health is short term for a very specific goal while you recover, and home caregiving is indefinite for as long as you need that service. Who pays for it? Home health is covered by Medicare and Medi-Cal, so both age-based and income-based. You do need a doctor's prescription in order to receive these services. Now, you can pay out of pocket. Um, my family member had a stroke. I tried to reach into, but she was too young. She didn't have Medicare. She just had regular insurance that didn't cover speech therapy as a result of the stroke. I called everybody I knew and I said, "Oh, can you do this?" And it was like, "Yeah, we have speech therapists. It's going to be over $100 an hour." And it's like, okay, well, that's, fine because we need it. We're desperate for it. But then it turns out they didn't even have anybody on staff that could do it privately. So it, while yes, there is the option to have that service out of pocket, Medicare and Medi-Cal will cover that cost. And to also clarify, for as an in-home care provider, you can hire someone who is a nurse, and it wouldn't be considered home health. You would just have your caregiver is a nurse who can provide a higher level of care, but that would again be at a very high cost. So again, home health, very specific goal, specialized medical care, need a doctor's prescription, versus in-home care is you determine what your needs are, you're paying privately for that service. Next, we have palliative care and hospice care. Both of these, again, are services that you can receive in your home wherever you call home. Hospice and palliative care both offer relief from the pain and symptoms of a serious illness, but they also address the social, emotional, and spiritual needs of patients and their families. So, again, let's look at both of these side by side because sometimes they're used interchangeably, but they are very different in what their purpose is. Palliative care, again, it's chronic progressive illness, but that person's looking to seek curative treatment. So, what does that mean? That means maybe someone has cancer and they are choosing to continue with chemotherapy, but they still want that extra support. For palliative care, there is no life expectancy requirement. So, at any stage of your disease process, you can qualify for palliative care. Palliative care is going to manage the symptoms. Oh my goodness, symptoms, and assist with advanced care planning while the individual continues to receive aggressive and invasive treatment. So someone will be there to assist with, what are your wishes? Do you have a pulse? Do you have an advanced directive? Let's get that set up. And for palliative care, care is provided in conjunction with your primary care physician or specialist. So you retain your doctors and your care team, and palliative care will work alongside with them. Hospice, on the other hand, is specifically for those that have a life expectancy of 6 months or less. Now, in my experience, people are very scared of hospice. It's very taboo. Don't want to talk about it, don't want to talk about death. And there's this idea that if someone was to go on hospice, they're going to die because the hospice agency wants them dead, right? I always like to say that hospice is a business like any other, and in order to make money, they need to have people on their services. So their goal is not for the person on hospice to die, but the goal is to make that person comfortable and provide support. So hospice is for someone with a chronic or progressive illness, and they are not focusing on cure, they are focusing on comfort. So the same individual that has cancer, they are electing to no longer receive chemotherapy. They want to focus instead on pain management and comfort. Again, it's about a 6 month or less life expectancy that is required for hospice care. This is continuously reevaluated. So if at that end of the 6 months, that individual is still alive, okay, well, let's look at them. What is our life expectancy now? Again, it's going to manage symptoms and help the patients and family transition with end of life care. So, hospice will be there to not only support the individual, but also support the entire family, provide comfort, provide spiritual needs if that's necessary, and help with any planning, any funeral arrangements. All of that will be taken care of with hospice. And what's different with hospice is the hospice physician will take over and be the head of the care team. So you will elect to no longer have your doctor, no longer have your oncologist, no longer to have those specific doctors. Instead, the hospice physician will be the one that will be making the decisions in conjunction with your wishes. Sometimes doctors have their own hospice agencies that they prefer to use. Sometimes hospice agencies are willing to work with other doctors. So if it's important to you to retain your primary care physician, talking to them about how can you do that. Otherwise, hospices have their own physicians on staff. And then this is just summarizing again, it's specialized medical care for palliative care, and it's at any stage of a chronic disease. And the goal of palliative care is to enhance a person's current care by focusing on the quality of life for them and their family, versus hospice, which includes an RN, it includes, someone for a shower aid, it includes all durable medical equipment or DME, so a hospital bed, oxygen, a wheelchair, a walker, all of that is covered through hospice, including medications, including continence supplies. They have a chaplain, they have volunteers for companionship, and they're available 24/7 to the family and the person that is on hospice. And one thing I will say about hospice is that I've seen several times that somebody goes on to hospice services towards the end of their life. And once they start getting such acute care, they have so much oversight. There's someone helping with medication, showering, that socialization. That person ends up actually doing a little bit better because they benefit from all of that care that they may have not been getting before. So, again, who covers the cost of it? Um, For both Medicare and Medi-Cal will cover the cost of hospice and palliative care. For hospice, you do need a doctor's order to go on to services certifying that your life expectancy is 6 months or less. You can pay out of pocket for these services for 95 for palliative care and 157 to 1400 per day, depending. But it's always best to go through insurance if possible. For hospice care, typically someone might pay out of pocket if they don't have a diagnosis or a certification that they're 6 months or less, but they're still looking for um, the services. And it's really important with hospice and palliative care that you go with someone who certified by Medicare. There are a lot of different hospice agencies, a lot of different palliative care services. Talk to them, find out what makes you different, what makes you special from all the other hundreds in Orange County or wherever you may live, and make sure that they are certified by Medicare. Now we have adult day programs and adult day healthcare. Now, these are still available for those living at home, but these are a form of respite care for both the care provider and the person living with the disease. So, adult day programs are going to be more of a social model, while adult day healthcares are of a medical model. Adult day programs and adult day health cares are both, they're usually open Monday through Friday from 9 a.m. to 5 p.m. And there is transportation that will pick up your loved one from the home, take them to the adult day program or adult day healthcare center, and then take them back home at the end of the day. So this provides the opportunity for the care partner to have respite during the day. And it also provides the person living with a disease an opportunity to socialize and have their care needs met in a safe environment. What are the difference between the two? Adult day programs have the optional to visit and create an assessment and do an initial assessment versus adult day healthcare that is required. Both are going to come up with an individualized plan of care. So, whatever your loved one needs assistance with, that's the care that they will be providing. So, if your loved one needs assistance to the restroom, they will do that. If they need assistance with eating, that's what they will provide. Both will have an activity program. Both have dietary services that provide meals and snacks. Both are going to come with transportation. At the adult day program, because it is a social model, they can assist with reminders to take medications. But at an adult day healthcare, there's a nurse on site that can assist with actually giving the medication. Social services are required at an adult day healthcare, but not required at a adult day program. So what that means is that there's a social worker on site at the adult day healthcare to help the family or the person navigate with, filling out Medi-Cal forms, any, social security, any of those tough questions that you need assistance with as you age and need help with guidance. For the adult day healthcare, there is uh, physician services. There is a skilled nursing, meaning there's an RN on site. There's physical therapy, occupational therapy, and speech therapy on site. Mental health services. So again, we're seeing more clinical, and there is more support. So if your loved one is doing fine, they're good, you have real no concern, then maybe the social program is good for them. But if there's issues, with mobility or cognition that could benefit from speech therapy, adult day healthcare would be a better option. And again, both are going to provide personal care and supervision. There are care aides on site. Now, Medi-Cal does cover the cost of adult day programs and adult day healthcare, as long as they are certified with Medi-Cal. Again, low income is Medi-Cal. Unfortunately, Medicare does not cover the cost of either one. There is an out-of-pocket cost for the adult day program of about $75 to $90 a day, with some centers having like aid or sponsorship opportunities, and adult day health cares are about $95 to $110 a day. And while it does seem expensive, and it is expensive, there are a lot of benefits to it versus an in-home care provider, depending on the need. In a home care provider, that amount comes very quickly. So when you look at cost, it's more efficient for the adult day program. Some people, they thrive with the socialization. It's nice for them to be around peers that are very similar or going through something that they are, where they can have a conversation. And maybe that conversation doesn't make sense to anybody else but them, but they get that opportunity to socialize, to engage in activities, to eat 3 solid meals a day, versus maybe at an in-home care provider can't provide all of that emotional and support. So just something to think about. But if your loved one is someone who's content to be at home in front of the TV and they really don't want to do anything, um, despite all of your efforts, then maybe an in-home caregiver is a better option for them. And now we're going to move on to out of home care options. So, this is what we're talking about when it's no longer safe or sustainable for someone to live at home alone. And that can be because of financial, that can be because of mobility issues. Maybe it's they're looking for more socialization, or maybe they're just tired of having to manage their life and they would like for somebody else to cook the meals and do their laundry for them. So we have a couple different types of residential care facilities for the elderly, or RCFEs as they're known. And these facilities provide room, board, housekeeping, care supervision, and care assistance with personal hygiene, dressing, eating, and walking. These services are going to be non-skilled and non-medical care. So the staff that's providing the care, they are not CNAs, they are not nurses. They are people that have been trained to be caregivers by the facility, but they have no medical background. And we have 3 different options within the RCFE world. We have assisted livings, we have boarding cares, and we have memory cares. Assisted livings typically look like this: big, beautiful buildings, lots of walking spaces, well kept. And assisted living is a type of housing designed for people who need various levels of medical and personal care. So, someone who is completely independent but looking for more of a social aspect, or again, just to offload the burdens of life of having to cook the meals and do the laundry, they may move into an assisted living. Or there may be someone there who has serious care needs and maybe they can't walk anymore. Maybe they need complete assistance with all of their ADLs. So, there is a spectrum. Living spaces can be individual, they can be shared. There can be 2 bedroom apartments, there can be studio apartments. So there's always a variety of sizes. And the goal of an assisted living is to be home-like. There are going to be wide open spaces, dining room, activity rooms, patios, backyards. It's designed to promote the residents' independence, and services are offered to assist residents with daily living. So with an assisted living, an assessment's done prior to move-in to establish what care needs are needed. That builds the level of care and also determines the cost, and that is then monitored on an ongoing basis. So usually someone can move in at one level, and as they start to need more care, the costs will go up, but they're able to still provide that care, typically to an extent. And then there is also boarding cares. Boarding cares are going to be very small homes, usually within neighborhoods, and they look like this. And boarding cares are also called residential care facilities or group homes, are small private facilities. Some have 20, about 20 people living there. Usually it's about 6 people max. Rooms can be private or shared. Residents receive personal care, meals, and have staff available around the clock. And then again, nursing and medical care are usually not provided on site. So boarding cares are much smaller. There's still that level of care. What care you need, they're going to provide. Typically, the staffing ratios, there might be 2 people for those 6 individuals, and they do all of the cooking and the meal preparation and the care. Boarding cares are wonderful. They're a very different experience, and it's completely based on what the person needs. My father-in-law is a very, very social man. He loves to talk. He loves to give his opinion on things. He loves to eat good food and then complain about the food that he eats. And he likes to just be a little bit bossy versus my mom, who is very quiet. She enjoys, going to church and reading. She's not terribly social. She has her close friends that she enjoys talking to, but she doesn't seek out other conversations. And she is a woman that loves Taco Bell. And that is what makes her happy. So when I look at the two of them, my expectations and what they would want and what I would want for them are very, very different. My father-in-law would do well in an assisted living where he can join the activities and be very social and maybe join the resident council and be bossy. While my mom, she doesn't need all that. That's not something that's important to her. So why pay for all of that when a boarding care would do meet her needs exactly where she is? So it's going to be very dependent on the person. And boarding cares, what's nice about them is they are smaller. So usually when people need a higher level of care, a boarding care is appropriate. And then we have memory cares. Memory cares can be standalone, where the entire facility is memory care, or it can be part of an assisted living where you walk through the doors and there's the memory care. Memory cares are designed to provide a safe, structured environment set with routines for lower stress for people living with various stages of memory loss. The goal is to be a smaller environment, maybe the raised ceilings, there's contrast on the walls with the handlebars. The doors are secured, so a loved one is able to walk freely and wander safely. When they get to the door, they press it, an alarm kind of sounds just to, deter them, and then they're able to wander off. The staffing ratio is going to be much higher because there are higher needs in a memory care. The staff will provide the meals, they'll help residents with personal care tasks, and there are going to be activities on site. Usually, with activities, they're more of a group activity versus an assisted living. The person has the choice to go, do I want to go painting or do I want to do exercise, or maybe I don't want to do anything. Versus a memory care, it's going to be highly encouraged that people join in on the activities. There's going to be more frequent checks from the staff. And again, since most people are out all day in a memory care, it kind of provides a different oversight. And again, just from my experience, typically someone walks into this, they're looking for their mother, they have a diagnosis of dementia. And they go to the memory care, they walk into the assisted living. It's beautiful. There's a beautiful dining room. The food is plated so well. There's activities. Everybody's social. Everybody's looking good. Then you go to the memory care and it's a different story, right? Different smells, different sounds. And while the residents are engaged, maybe they're not as verbal. Maybe the staff, is handling a behavior at that moment in time. And they think, well, this isn't what I want for my loved one. It's not small. It's too small. There's no backyard. They can't roam freely and choose what they want to do. And so that loved one ends up going to assisted living. And then that loved one fails in assisted living. They are lost. They don't know where to go. They hang on to staff. They usually sit at the concierge desk all day. They can't participate in activities because they don't understand. Maybe they don't go to meal times because they don't have anybody to eat meals with, because they know that they're different and the other residents know. And then eventually that person ends up moving into the memory care where they thrive off of the smaller environment with more staff and people that they can connect with. So it's really important when you're looking for your loved one or for yourself or helping somebody, that the person goes where they need to go, where their needs are going to be met and not what you want. Because yes, the assisted living is beautiful, but that doesn't mean anything to the person with memory issues. They need a safe and small environment. And now people with dementia can live in a boarding care as well. Typically, the excluding factor would be if there's wandering and exit seeking. But if there are behaviors with dementia related behaviors, a lot of falls, typically a boarding care is a better option for that one because, again, it's a smaller environment. And though there's less staff there because everybody's kind of in a living room together, there's more oversight. If great, so someone asked a question: if I have a dementia diagnosis, does that automatically mean they have to be in memory care? Theoretically, yes. So assisted livings are not supposed to take someone with a diagnosis of dementia. However, they still do. It's at their discretion. Sometimes it's, oh, well, maybe it's mild cognitive impairment and not, a type of dementia. Or maybe they encourage the person to wear a wander guard. So, no, you don't necessarily have to go straight to memory care. And especially in the very beginning stages of the disease, a memory care might not be the most appropriate, but just being open to that conversation. So, if you're very, very early stages of dementia, consider assisted living, consider care at home first, but just know memory care is most likely down the line if that's what you want, and that, open to it and finding one that you like. And then a different type of this is what's called continuing care retirement communities. And these are life plan communities or CCRCs, and they are considered a long-term care option for people who want to stay in the same place throughout the different phases of the aging process. So this can be a large campus where they have an independent living, assisted living, memory care, and typically a skilled nursing facility. Now, some are independent and assisted living are in one building. So you move in independent, and when you start to need care, care can be offered to you, or maybe it's in a separate building. These are ideal for people who are maybe married and one person needs a higher level of care, like a memory care, while the other person is maybe still independent. So it is a nice option to have everything on one campus. Now the cost. So Medicare does not cover any aspect of assisted living's boarding care, memory care, continuing care retirement. There is something called the Medi-Cal Assisted Living Waiver Program, or the Assisted Living Waiver Program, that's covered by Medi-Cal, again, low income. This program has about a 2-year wait list. It's a phenomenal program. There's just not the capacity. If your loved one does go to a skilled nursing facility and they do have Medi-Cal, you can always speak with the social worker about helping apply for the assisted living waiver program, and it will expedite it. And out of pocket cost is going to vary. It's going to vary on location, size, and it's going to vary based on the level of care. So looking at these numbers, this is for room and board. So the starting rate. So for an assisted living, that's about $4,500. Board and care for a shared room is about $3,000, with private being $4,000 to $7,000. And memory care is about $6,500 for just the room and board. What's nice about a boarding care, it tends to be more all inclusive. So maybe it's, you move in, it's 4,500 and the next level would be 5,500, but there's not going to be those points that you might see somewhere else that, like, once, okay, you want 2 showers, it's this much, but if you want 3 showers, then it jumps to this much. Now with continuing care retirement communities, there tends to be an entrance fee about $400,000, and then on top of that, a monthly fee. And it's really important that to be conscientious of continuing care retirement communities, and it's been in the news a lot lately. If the building shuts down, you may lose all of your money. If the plan is to live the rest of your life at a continuing care retirement community, but it's at their discretion, and they may not be able to meet your needs, or you exceed what they can provide, and they might not refund any of your money to you. So it's usually a very hefty down payment, and then will you get all of that back? So just if you're something you're considering, again, they are a great option. Please just be very mindful, read the fine print, ask the tough questions. Now, a question came in about long-term care insurance. Depending on your coverage, long-term care insurance can help offset some of the cost. Typically, it's dependent, like, okay, do you need assistance with at least 2 activities of daily living? But that's going to be specifically a question for your long-term care insurance if you have that in place. But there are those that do help cover some of the cost. Next, we have skilled nursing facilities. Now, skilled nursing facilities are a medical facility. They're for those of a higher level of care. They are going to be considered a transitional care. So from a hospital stay, not quite ready to go home, you can go to a skilled nursing facility for additional nursing coverage and rehabilitation. Registered nurses, licensed vocational nurses, certified nursing assistants are on staff and the ones providing care. And there will be a doctor that comes on site. It's 24/7 nursing coverage. And again, there's going to be physical therapy, occupational therapy, speech therapy, social engagement, activities, meal preparation, personal hygiene. So they do it all. And again, this is going to be for a stay after a hospital stay where you're just not quite ready to go home. This is the tricky part. This is where people get confused because of how many rules, and it's not crystal clear. Now, Medicare, traditional Medicare, straight Medicare, all Medicare, I should say this, covers up to 100 days. So if you have Medicare, you have a Medicare Advantage plan, they will cover up to 100 days. Days 1 through 20, you pay zero. Days 21 through 100, you pay up to $194 in co-insurance, copay. Now, people, and this has kind of been my, where I've been throughout my career, is people come into a skilled nursing facility and maybe it's because they broke their leg, they broke their arm, they had pneumonia, and they didn't have the strength to go home. Okay, what's your plan? What are you going to do? And so, well, I'm going to stay here and I'm going to get rehab. It's like, okay, great. What's your plan for when you go home? You live on the second story, you have stairs, you live alone. Who's going to provide care? Oh, we'll figure it out as we get closer. So that resistance to talk about it from day one. And then also, if you have a Medicare Advantage plan, you've elected for a company to manage your Medicare benefits for you, which means they will ultimately be the ones that decide how many Medicare days that you're going to use during that stay. So yes, while you have up to 100 days, it does not mean that you'll get to stay that 100 days. It'll be at the discretion of the doctor and the insurance company how many days. Usually the goal is, can that person walk 100 feet? If so, great, they can go home. Regardless if there's stairs, if there's somebody to assist them at home, it doesn't matter. So if your loved one ever goes to a skilled nursing facility, you need to have a plan starting day one. You need to have that plan in place at the hospital of what's going to happen for my loved one. Because again, home health is very, very short, it's nothing. You need to have in-home care, assisted living, memory care. What is that option for discharge? You can pay out of pocket for a skilled nursing facility. And that's what we saw earlier, is that the Medicare days ran out. So the family had to pay privately. Medi-Cal does cover. If you have Medi-Cal in place, you can stay with the skilled services, meaning the physical therapy, and you can also stay long-term, what's called a custodial resident, meaning that they live there. They have the nursing staff take care of them, but they're not receiving rehabilitation services. So again, it's to stress it, day one, have a plan in place because regardless of how many days you're there, it's too short, it's never enough, and the discharge date's going to come. And in order to qualify through Medicare for a skilled nursing stay, you do have to have a hospital stay of 3 nights prior to um, that stay. So, and you had to be admitted to the hospital too. So it's really important. You just can't, go to a hospital, be in the emergency room, and then qualify for a skilled nursing stay. So how do you plan for the future? It's hard. Nobody wants to talk about it. We always hope for the best, but we need to start planning today. We need to know, what can I afford? What can I afford? What are the companies that I like? What are the assisted livings that I like? Even if you don't think you'll need them, or hope that you don't need them, you've at least done your research. You know the cost, you know what to expect. So, legal and financial planning, having a power of attorney, an advance directive post. What are your long term care insurance? What are the public benefits? Are you a veteran? Do you have a Medi-Cal? Looking at the full picture of what you have in front of you and who will pay for what. It's really important to sit down and communicate and have family meetings regarding this, especially if there's a lot of siblings that are going to have to make decisions, and but including the loved one, or your parents in the conversation of what is it that they want. They'll be resistant. And that's why just slowly starting and looking at places. Well, maybe you would like this place and let's just go take a tour. That's all we're going to do. But at least to get the conversation going. And once they step foot inside of an assisted living, they'll see like, oh, it's actually not that bad. It's not what I was expecting. Because a lot of the times they don't want to feel old. That's always what my mom says to me. I don't want to be old. But when you go and it's not old people, it's just like it's people hanging out, it's people socializing and enjoying their life. And you want to, the conversation's difficult, you just have to start it. If it gets too overwhelming and too emotional, you pull back and you revisit it a different day. And you always want to just involve the important family members. And if there's somebody that can be a facilitator, like a third party facilitator, such as also C or a social worker, case manager, getting them involved as well. There are care navigation resources such as geriatric care managers that can help facilitate the conversation or help with finding locations. The area agencies on aging, Alzheimer's Orange County, palliative care, and hospice agencies, they can all be of assistance during these conversations. And it's really important to think about how planning pays off. It provides peace of mind. It allows for that person to have more control over choices. So decisions are not being made for them. They are in control of what happens to them in the future in the sense of where are they going to live. And it's overall better outcomes for everyone. So that is the presentation. I know it was a lot of information. Again, I will be sending out the slides. This will be recorded and available on our YouTube. I really quickly want to talk about our enhanced case management program. So we are contracted with Cal Optima Medi-Cal, and they were finding that they had a lot of people who were utilizing the emergency room and the hospitals a lot more frequently versus going to their doctors and focusing on preventative and proactive care. And they thought, how can we help? How can we get people into the doctor before they need to go to the emergency room, or only going to the emergency room for appropriate reasons? And so they decided to come up with the enhanced case management program, but then they don't have enough staff to support this. So they have outsourced that to various organizations. We are one of those organizations. And our goal is to help people stay at home and live longer at home independently. So that means assisting with doctor's appointments, getting authorizations. We had a gentleman who desperately needed hearing aids to improve the quality of his life, but he could just not get them. We were able to work with his doctors and the insurance and get him hearing aids. So it is whatever you need in order to live at home independently, whether that's Meals on Wheels, helping with, services for rent, whatever it may be, that we can be there for you. Again, this is specifically for Cal Optima Medi-Cal members, but it is a free service. And now I will, if anybody has any questions, please do reach out, put them in the chat box, come off mute. For our name of our YouTube channel, it is I just type in also see YouTube. I will put it in the email that I follow up with, but if you do also see YouTube and Google search that, it'll pop up. Lucky put in that the Anaheim Public Library is conducting a survey and would like to know if you would like more programs like this and others. So if you have time to please complete the survey, there's a link. Thank you, Lucky. The surveys are tedious, but they're so important. They allow for us to know how we can better serve the community and what it is that you want to see so that we can provide those for you. Um, I'll put the link in the email as well. So we appreciate you taking the time to provide your feedback. And then lastly, this is our helpline number as well. So if you have any questions regarding care options, we have hundreds and hundreds of resources. So if you're looking for assisted livings, if you're looking for someone to assist with placement agencies, skilled nursing, Medi-Cal lawyers, anything of that nature, we can send you our referral list. We can help you in that journey because there is an abundance of information and it can be very overwhelming. What do I need? When do I need it? But we are here to help you. We can help you with caregiving issues. We can help you with brain health. We can do it all. We may not be the organization, but we'll direct you in the right one. And then if you have information, if you want information on the Enhanced Case Management Program, you can call that number as well. Any other questions? No? A quiet group? That's okay. Please feel free to email me. Again, my name is Lauren. You can just respond to the email I send out. I want to again thank Lucky and the Anaheim Public Library for helping us to put on this presentation and supporting us in our education for the community. So if nobody has any questions, I will see you all next month. Have a great rest of your day.